Coming up today, a spotlight on women's health, from mammograms to maternity and managing a healthy weight. We hear specific considerations for women of any age. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. If you look at history of medical science, generally speaking, most research has been done by men for men. Thankfully, though, we have come a long way in terms of acknowledging health concerns specific to women. Today, we are honoring Women's Health Awareness Month with a discussion that we hope empowers and uplifts women. We're talking with three experts in their respective fields this morning. Joining me today is Dr. Mark Parrish, an OBGYN and maternal medicine specialist here at the health system. Across from me is Dr. Annalisa Winblad, a breast imaging specialist and the division director of breast imaging at the University of Kansas Cancer Center. And Dr. Anna Gorsica is an epidemiologist and researcher at the University of Kansas Medical Center with a special focus on weight management. So great to have all of you here with us today. Good morning.
Good morning.
Good morning. Okay, so before we get to each of your specialties, I do want to ask a question that applies really to every woman, because time after time we hear on this program when female patients come on, when they're at a doctor or they're explaining a health concern, that they're often feeling like they're being dismissed or maybe not taken seriously. So how can we empower women as they start their health journey? Dr. Winblad, we'll start with you.
You know, women know their bodies best. If you feel like your concerns are being dismissed, seek a second opinion. Women tend to take care of others and go to bat for others, but you can't be a source of strength unless you're healthy. So be an advocate for yourself. Get that second opinion if you don't feel comfortable with the first.
Dr. Parrish, your advice.
I agree. I can't say it any better. I think you need to know that you need to be your own advocate. And if you don't feel like you're being listened to, then find somebody that will listen to you.
So why aren't women being listened to? Or why do they feel like they aren't?
I think, you know, women experience different symptoms than men. And as you mentioned, I found this fascinating. I was doing some research, and I believe it was 1995 when women were first allowed in clinical trials, which was only 30 years ago. So a lot of this work that's been completed is not done in women. And so a lot of the way that medical textbooks are written are mainly the way that men present. And so I think really discussing that with other females, and like both Doctors Winblad and Parrish said, you know, being your own advocate and really making sure if you're not being taken seriously, you have no requirement to see the physician that is, you know, not providing the best care for you, and you can always find another opinion.
I'm sorry, you have to repeat that. When were women allowed to be a part of clinical trials?
1995.
Across the board?
Uh-huh.
Okay, that's going to be hard to beat this week to shock me on this show. Okay, so Dr. Parrish, when it comes to maternity, America unfortunately has a significant maternal mortality problem. You're a part of a team devoted to helping moms deliver healthy, happy babies, but overall, maternal mortality statistics in America are trending in the wrong direction. It is not a simple answer, but what are you finding and what can be done?
You know, it's absolutely not a simple answer. And if you look at everything on the surface, so the CDC will, using this national vital statistics information, will look at maternal morbidity, mortality, you know, on an annual basis. And every year, as you look at it on a graph, you're like, how are we getting worse? And if you look at us on a list of other countries or worldwide, we fall below some countries that people would consider to be third world countries. And you're like, how the heck is that happening here in the United States? The reason it's much more complicated than just looking at that is that it's how we do our surveillance. We're a lot better at identifying these risks. There's also errors in that surveillance. There was actually a recent study in March of this year in the American Journal of Obstetrics and Gynecology that showed when we use the traditional benchmarks on the death certificates to mark if this was a maternal mortality, there's a lot of gray there. And if they compare it to how things are currently done versus taking that same information and actually specifically looking to see if it was pregnancy related or if it just happened to be that they were pregnant but were diagnosed with cancer or had trauma, were in a car accident and died because of that, when you start to look at it that way, really we're actually not doing as bad as what it looks like on the surface.
So maternal mortality could, if somebody was in a car accident while they were pregnant, that would check the box?
Yes, it checks the box.
Okay, clearly that's not what we're talking about.
Right,
when
right,
we talk about maternal mortality, we're talking about a lack of access in a healthcare.
Absolutely.
Tell us more about that so we understand.
I was going to say, I need to elaborate further. So I don't think we're doing as bad as what we think based on those numbers. However, we still need to be doing better, because when you start, again, digging down even deeper, and we'll take the state of Kansas, for instance, you start to get out into a little bit west of here and keep going west, those maternal, they call them the maternal deserts, you're going to see higher rates of maternal mortality, higher rates of newborn mortality, because those services for moms and their babies to have somebody that is adequately trained to take care of more complicated pregnancies, they just don't exist. And so those patients are at have a huge disservice that's occurring to them and their families, because outcomes remain certainly poor in those rural areas.
It comes down to access, it seems like all the time. Dr. Gorsuch, it's important that women be as healthy as possible before they get pregnant. What has your research shown as far as pregnancy and weight and how they relate together?
Sure. So to take a step back, there's a lot of evidence showing the negative impact of obesity on maternal outcomes as well as fetal outcomes. And so some people jump to the conclusion that if obesity is bad, then weight loss is good, and that can help with pregnancy. And it's very specific. We're getting into more of kind of modernized, individualized medicine, and so there's not just a blanket recommendation for women if they're overweight or obese and they want to become pregnant on those pregnancy outcomes. However, we just did a meta-analysis, which is taking all of the best research that's been done, which again, back to the clinical trials, hasn't been a ton, and we found that lifestyle interventions were specifically the most beneficial on pregnancy outcomes, but there's just so little data on live birth and then miscarriage and other fetal outcomes. So right now, we know that lifestyle interventions are beneficial on pregnancy rates, but there's so much that we don't know leading up to live birth and then specifically miscarriages as well. And there's a lot of other components to this, such as whether or not they were seeking fertility treatment, whether they had PCOS or anovulation, which are some other markers that kind of present very similar to cardiometabolic disease. So those populations of women tend to respond better to the weight management interventions on pregnancy outcomes. But there are a lot of fertility diagnoses that might not benefit from weight loss, and a lot of the trials that have been done just kind of group everyone together, and so it's hard to really parse that out.
Right, so research continues in that area. So just last week, I want to talk about a headline, and that was another hospital in our area, Providence Medical Center, ending their labor and delivery services. So Dr. Parrish, is this just a matter of volume? Is this what gives with that?
We certainly believe that it is a volume issue, and again, access issue. Having doctors in that area that are able to, I know that's still in the Kansas City, Kansas area, but having those physicians that are employed by by Providence, I know there's just. I would say there's some question about, if they were willing to still be employed, there's question about profitability, certainly there to labor delivery. I think that it's again, goes back to it's complicated, but a lot of places aren't willing to take the risk if you don't have good volume of patients coming through the doors through a labor and delivery service, because this business is certainly risky. It's an understatement to say that, and there can be complications. And places aren't willing to take that risk if they don't feel that they can provide adequate services for those women and their babies.
So let's talk maternal mental health, women's mental health in general, whether this is postpartum, during a pregnancy, anytime during their life. But what are some specific issues that maybe pregnant women deal with when it comes to their mental health? Yeah,
so I think that I always try to tell our patients that, I think your mental health is just as important as your physical health. So we have moms that we take care of that have pre-existing conditions like hypertension or diabetes. And if you don't control those things, you're going to have poor pregnancy outcomes. The same is true when you're talking about mental health. And those are things that I feel like that there's been such a stigma, and it's gotten a lot better, but there's still this stigma that is a conditioned problem where people just feel like, oh, this is something that, it's just your hormones. It's causing you to feel this way. And that just gets pushed off or dismissed. And I think again a huge problem for us to just ignore those things because, going back to maternal mortality risks, suicides are also in those situations. Domestic, intimate partner violence are in those statistics. And mental health issues play strongly into those things. And if you're not addressing those things, again, having horrible outcomes for moms and their babies, either during pregnancy or I would say you see an even higher risk of those outcomes occurring after the delivery in the postpartum period.
Dr. Gorsica, jump in on that because you're right. He mentioned it. We're just kind of told to just blame everything on the old hormones. They're just kind of out of whack, so deal with it.
Absolutely, and I think it really goes back to self-care, kind of what we said at the beginning, and you really have to take care of yourself if you want to be able to take care of others. And I think pregnancy is probably the best example of that. And if you can really manage that side of things and have those conversations with your physicians, that's really a way to stay ahead of it going into the postpartum period and then just along the lifespan.
We want to take a moment to highlight a really great resource, the National Maternal Mental Health Hotline. Information's there on your screen. Anyone can call or text there. This is 24/7. You can speak with a trained counselor who specializes in maternal mental health specifically. That number, 1-833-852-6262. That spells out 1-833-TLC-MAMA, as in tender, loving care for the moms. So, Dr. Winblad, let's bring you in and let's talk about mammograms because there's still a tiny bit of confusion, as usual, especially when it comes to screenings about when to get them. So you have the best medical advice and the government guidelines still not lining up. So remind us, when should someone, just in an average risk, get a mammogram?
The universal recommendation is for all women who are average risk to start screening at age 40. When women screen every year starting at age 40, the death cancer rate from breast cancer drops by up to 42%. Breast cancer is incredibly common, so breast cancer screening is crucial. And when women screen every year beginning at age 40, we have the best outcomes.
So what about someone younger than 40? How do they know if they're at a higher risk, and then when should they approach and get their mammogram started?
For some women, starting at age 40 is just not early enough. I recommend all patients have a breast cancer risk assessment by age 25 so that they can determine whether or not they are at high risk for breast cancer. We know that women who are higher than that average risk should start breast MRI screening. That's a more sensitive type of screening test at a younger age, typically around age 25, and mammograms may start shortly after, around age 30. So it's imperative that you know your breast cancer risk before you're 40 so that you know whether or not you need to start before that starting age.
So if it's just that you have a family history, that would tip you off to go in early. But where do you get a breast cancer risk assessment test?
I would recommend going to your primary care physician, asking about breast cancer risk assessment. There are many different, programs, even electronic programs online where you can put in different factors such as age, family history, history of chest radiation, a bunch of different factors to determine if you may be at higher risk. But your doctor can also recommend you to a high-risk program if they're not certain. At KU, we have a wonderful high-risk program. So if you have a strong family history of breast or ovarian cancer and family members at a young age, history of chest irradiation, other factors, you may qualify to see a special type of physician who specializes in high risk.
Artificial intelligence, AI, it is the new buzzword as we know, but with mammograms specifically, your team has been using AI to help mammogram techs while they're taking those images. So how is AI helping?
We have several different programs that help us provide the best quality of images for our patients. One of those is a tool that evaluates our mammogram positioning. It evaluates the breast compression that occurs during each mammogram image. It evaluates the radiation dose, several factors that then are reported back into this program and allow us to provide performance feedback, essentially. We know when we get the best images, the best quality images, the radiologist is able to find breast cancer. When it's small, images are incredibly, crucially important for us being able to identify breast cancer. So mammogram positioning and performance is incredibly important. And we have invested in a tool that really helps us perform really well.
Well, that's one great thing about our cancer center is you're a breast imaging specialist. Not every place has a specialist. You look at images of breasts all day long, and then this is just an extra layer.
Yeah,
to
this
help
is an
you.
extra layer. So not only am I a specialist that does this all day long, our technologists are specialists that do this all day long, and they get even better and better because they have that performance feedback, and over time they just continue to get better.
Dr. Gorsuch, a lot of research that you do is dedicated to physical activity, weight management, and the numerous benefits that we know come from it. We talk about those here on the program all the time. And of course, there are applications that apply to both men and women differently in many cases. But for women specifically, what are some challenges in maintaining a healthy weight? Please tell us. Give us all the details.
Sure. So I think, it really starts with a lot of the life transitions that happen with women. So once, they enter pregnancy, if they're having multiple pregnancies, they go through that postpartum period. And as they're, reproductive aged, they then move into menopause. And with menopause, there's a lot of stages and a lot of misinformation and really just no information. So I think one of the biggest things moving through that menopause transition is the change in hormones. So the estrogen decreases, and with that, there's also physical activity that's decreasing. There's a lot of life changes that are occurring all at the same time, and so that really makes it a challenging period for women specifically to manage their weight.
I have no idea what you're even talking about. Yeah.
I will say, though,
I know it all too well.
People are starting to talk about it more, and I think that's really good too. I think it's what's hard, and I would love to actually hear your guys' opinions on it, but from my opinion, not a clinical MD or anything like that, but medical school, when you're in the OB-GYN rotation, it's very focused on pregnancy and postpartum, and menopause is not as much of a focus. And so I think, where do women go to find that information? Is it their PCP? Is it their OB-GYN? Is it, is it their endocrinologist if they already have some other chronic conditions?
Lots of different specialized places to go.
Sure, and yeah.
Dr. Parrish, where do you go? Where do you start?
Yeah, I do think your primary care physician or your OBGYN, I would say both, would be at least knowledgeable enough to say, let's have a conversation about it. And if there's something specific that we really need to address, we would need to kind of shuttle you to the right specialist to see you. And so those two would be the most common. I feel like, as you said, it used to be going through your OBGYN rotation. Maybe there was a higher focus on the obstetric side of things, but these days it's a focus on the entirety of women's health.
Sure. Dr. Wimblad, jump in on menopause.
I was thinking this just comes back to historically there's not a lot of science about women, and the symptoms that women have. And menopause is just another area in which there's historically a lack of research. So I think this is getting better. I think we're all becoming more knowledgeable about women's health and, menopause, perimenopause. So it'll be interesting to see, in the next 10 years how this all evolves and changes and the support that women have as they're going through different transitional periods in their life.
What's really interesting in the literature, I have a background in exercise physiology, and so a lot of that work started with high-trained athletes and endurance athletes. And when I was in grad school, women were excluded from those exercise trials because of the menstrual cycle, or if they were on oral contraceptives, and so they just were excluded. And that's kind of similar to what we see with the perimenopause stage in weight loss and in weight management trials and physical activity, because from a research standpoint, it's very hard to control or measure all of the different factors that could be influencing weight and physical activity, so it's just been easier to exclude. But I'm going to change that.
Well, but growing up, we'd hear the word menopause, like, oh, that's something my mother's going through or my grandma went through. And then this perimenopause, I'm like, where did that even come from?
Sure.
Like, that is like the biggest gray area on the planet.
And that's really the part that when women talk about menopause symptoms, it's really happening during perimenopause. That's kind of where all of the symptoms are happening, the hot flashes, and a lot of the changes are occurring because menopause is really considered 12 months after the final menstrual cycle, and that's really when all those hormones are changing and the symptoms are really significant.
And I think I was going to just kind of use this to plug that, it's historically we've done a very poor job of including women in research. We've just kind of been honing in on that. We are doing an atrocious job of including pregnancy in these research trials. And I get it from a 10,000-foot view. You're like, well, who wants to do research in pregnancy? That sounds maybe like it's immoral, but I think it is actually immoral to not include these moms in these trials, because we're afraid to do anything for these patients that may be helpful, depending on, because there is maybe a risk to the baby. But when you look at the majority of the medications we take care of moms that have autoimmune disorders, histories of cancer, active cancer, I mean, many crazy things in pregnancy, there usually are markedly more benefits of that mom going through getting treated than there are risks to the baby. And people just don't realize that. We don't have the data because research doesn't allow for pregnant moms to be involved. So thanks for letting me plug that.
No, I'm glad you did. I'm really glad you did.
It's such an important point. This is the same in the breast cancer world. Pregnant women are excluded not just from breast cancer research, but breast cancer screening research. And pregnancy-associated breast cancer has an incredibly high mortality.
Yes.
It's incredibly important that women who should be undergoing screening are screened when they're pregnant. And, there's a lot of historical misinformation about pregnancy and screening during pregnancy or breast cancer treatment during pregnancy. And those are actually patient populations, especially as our pregnant population gets older, that is incredibly important for us to focus on in the
are
breast
breast
cancer
screenings
world.
happening during pregnancy, or are they not allowed to happen?
Absolutely, they can happen.
Okay.
In fact,
People think they can't.
But I still have patients come to KU saying that I showed up for a breast cancer screening test and this was, they sent me away. And because I think that historically has been kind of traditional, standard of care in some practices. And the reality is, if a patient is at the age or whatever their risk status may be for screening and they're due for that, it's incredibly important, because they might even be not just at higher risk, but their mortality from breast cancer is much higher when you're pregnant. So it's just something important that I think we're talking about more, and patients are being included more, hopefully, in research, but it is challenging. It's really challenging to include patients who are pregnant in research studies because it's hard to standardize results and things like that.
I'm really glad this conversation kind of took a turn to getting women involved in studies. So I'm going to turn to you and say, how do we do it?
Absolutely. So that brings up a really good point too. So a lot of the work that's been done with weight management and physical activity in women. So if you think about it, from a research standpoint, you want these women to go through an intervention to see if it's effective, and if the outcome is pregnancy, then you have to be preventing pregnancy during the intervention. And so that is, specifically a focus. But then at what time point do you wait to measure when they then get pregnant after they've been, gone through the weight management intervention? And so I think when we were talking about, women being excluded from things, there's been a lot of talk about the anti-obesity medications specifically. And, in this meta-analysis that we did, we were able to separate out lifestyle-only interventions with those that included anti-obesity medications. And we did see that the interventions without anti-obesity medications were better for pregnancy rates. That was really kind of driving the results. But it's important to note that these AOMs are very new, right? But they're also accessible. So if women can, if that's the way that they are being treated for obesity, to then, have better cardiometabolic outcomes and potentially pregnancy outcomes, there needs to be more research done.
What's an AOM?
Following that anti-obesity medication.
Anti-obesity medication.
Sure.
Okay, so where can women go if they're listening right now and just want to find out if there is a trial, pregnancy or not? Just women. We need more women involved. Where can they go?
Sure. They're actually, so both Novo Nordisk and I believe Eli Lilly, so those are the two big drug makers for the anti-obesity medications, and they have pregnancy cohorts that you can join if you're on those medications. So if you're on semaglutide through Novo, you can join that, and then they're going to follow those outcomes. So I think, a lot of women's health research has been epidemiological based, meaning that it's observational or cohort, so that they're not intervening, but we can kind of tell these time component lifespan outcomes across across the lifespan. But I think for women, the thing that you can do is get involved in research.
Yep.
Talk to your primary care physician, reach out to go to clinicaltrials.gov. There are a lot of opportunities to be involved, and that makes me very happy.
Yeah, that's a good legacy to leave. We have more questions for our experts, and if you have any questions, send those in using YouTube or Facebook. We are on the X platform, or you can email the Medical News Network. The information is right there on your screen. Let's talk real quick. Let's go around and talk about misconceptions in your fields. So, Dr. Parrish, when it comes to patients that you talk to, what is something that's just flat out wrong that they come to you with?
Yeah, I think we've been talking about some of it right now. It's like, okay, you can't be treated for certain things. You can't undergo screening for certain things. Another thing that we had a conversation about before we were on air was just when you should initiate your care. I think people think that I'm young, healthy, indestructible, and I don't need to start seeking care. And oftentimes, patients are entering healthcare pregnant, and so it's the first time they're ever seeing a healthcare provider. So I think that's another common misconception. It's important that even if you're young, that you're seeing a primary care physician, making sure that things are being identified that you may be at risk for based on weight or family history. Those things certainly can be impacted by pregnancy. And so, having a knowledge about those things before coming in and being pregnant can have a significant positive impact on pregnancy outcomes.
Dr. Whitblad, mammograms. What anything else to add about people getting anything wrong when it comes to that?
A lot of people think I don't have a family history of breast cancer, so I don't need to start screening and I don't need to, get a mammogram. In fact, most of the people diagnosed with breast cancer don't have a family history of breast cancer. So if you're at screening age, come get your mammogram. Get your mammogram every year. Breast cancer is so incredibly common, and we can do the best job by finding cancer at its earliest stage when it's small and treatable.
Any misconceptions around weight management?
A lot.
What are the biggest? What's the biggest?
Sure, that I think one of the biggest is someone hears that another person was successful with, X intervention, whether it's, keto, high intensity interval training, et cetera, that just because someone else was successful means that it will be successful for that individual. And I think it's really important to focus on what is able to be implemented into your lifestyle. And so if you're, somebody does juicing and they lost, 50 pounds on it, like, is that really feasible for you to implement into your life? And so really starting small, and the best thing for you is something that you can sustain and maintain and incorporate into your life when it comes to lifestyle behaviors.
Let's talk about something else, because whenever we have a chance, we want to highlight the importance of the HPV vaccine. It is effectively a cure for cervical cancer, preventing it from happening in the first place. So please ask your doctor, ask your kids' doctors about the HPV vaccine. And Dr. Parrish, we saw a recent headline about an HPV test that women can perform themselves without going in for a pelvic exam with a doctor. So any thoughts on this DIY HPV test?
I think the jury's still out on this. There's some studies that have shown that there could be benefit to those patients that are just absolutely afraid of going in to have this type of screening performed. But I still think the best case scenario, even if you consider doing this do-it-yourself test, is having a conversation with your primary care physician. Make sure you're doing it correctly. I would say there can be some error in how it is done. And so I think it's a great thing, but I also think the best case scenario is you still go in for an evaluation by your primary care physician.
All right, I want to get to some questions from our viewers, and Jeremy has one. He was talking about, he's at home listening to his wife when she comes home from the doctor, which I like to hear, but just the concerns about asking your doctor, who maybe you do have a pretty good relationship with, hey, I want a second opinion. So where do you start with having a comfortable conversation when it comes to that, whether it's breast or when it comes to having a baby or gynecological needs?
Yeah. So, I think we encounter this quite frequently because we're having conversations with moms with maybe something that's seen on an ultrasound, for instance. And that can be, it's a very sensitive topic when you're talking about a baby that has, a condition that could impact the baby's life for long term. And so, I always encourage, I think it's important to offer that second opinion to patients and say, hey, we can set you up with a second opinion from, somebody outside of this realm. We live in a small world in our subspecialties that we live in, and we know people in the community, and oftentimes I feel like most of us have good relationships with those other subspecialists or specialists, however you want to put it, and can refer those patients for a second opinion. So I think it's important, number one, no matter what you're talking about, I'm kind of focusing on the field that I'm in, but to encourage those patients, those women or men, if you feel that you're not quite certain what to think about what the doctor is telling you, and you want a second opinion, ask that doctor, either, hey, do you have guidance? It may sound weird to go somewhere for a second opinion, or just keep it to yourself if you don't want to feel awkward, and go
Just
seek
go get
that
it.
second
Don't
opinion.
ask. Just go.
Yeah.
You don't need somebody else's
Right.
permission.
Exactly.
Brenda has a comment and a question. She says, yes, we need more training for menopause. Too many women are suffering needlessly. Depression drugs are not the answer. New studies support HRT. So doctors need to keep up with current treatments, she says. What are your thoughts on hormone replacement therapy?
Anybody?
Anybody wants to jump on that one?
I will just, from a breast cancer
Please.
screening perspective, if someone's on hormone replacement therapy and they've talked with their physician about that and it makes sense for them, I support whatever their medical plan is with their provider, but make sure you're getting screened. There may be an increased incidence of some types of, breast cancer, very low, increased risk, but studies show that may exist. So make sure you're getting your proper screening. If you're on hormone replacement therapy and you're above the age of 40, even average risk, make sure you're coming in every year for your screening mammogram. If you have dense breast tissue, make sure you're getting your supplemental screening test. That way you are doing the appropriate, screenings for that patient.
Carol has a question. Neither gyno nor PCP is up to date on the information for older women. I was told you're old and don't need hormones any longer. According to them, your body needs no form of any hormones. She says, tell that to my thyroid. It's not just about hot flashes. She says, I'll never return to that office. Quit putting us in a box and making us feel invisible. She says she needs a gynecologist who is open to new information and who really cares. So the question is, how does Carol find that specialty care?
I think talking to friends and family is really important. Having these conversations with other women that are seeking care it's a slippery slope, I will say that. So, tread lightly, but I think getting that recommendation from other people that you respect is definitely one way to go if you don't have a connection to the medical community, or you just don't know, maybe you're in a new area and you need care, just really, trying to determine how to get that and who's had a good experience.
Before we wrap up, Gene, I want to agree. He says, most shocking news from the program today, women not allowed in medical trials before 1995. I cannot agree more. So there's more conversations to be had.
That is a stat. I was shocked.
I think we all are, but hopefully it hit somebody.
Yep.
And the phones ring on those. So what's the biggest takeaway, Dr. Winblad, today?
For me, I always tell people breast cancer is common. Globally, it's the most common cancer in women. So have a breast cancer risk assessment by age 25 so you can find out when you need to start breast cancer screening tests. If you're average risk, start at age 40 and be screened every year.
Dr. Parrish, what's the big takeaway?
I would say some of the things that we highlighted here, I don't think that you automatically need to just stop your medications altogether because you found out you're pregnant, or you've got to stop getting screening for certain things that you've been getting screening for. Don't be afraid to ask your doctor. Don't make assumptions that you just have to stop because you're pregnant. Just because you're pregnant does not mean you can't get the right treatment and the right screening.
Dr. Gorsica, biggest takeaway?
I think it's really important to incorporate lifestyle changes, whether that's physical activity or eating more fruits and vegetables, and do it in a way that is enjoyable, whether that's cooking with your family over fruits and vegetables, or having a dance party in your kitchen with your kids on a Friday night. Whatever is going to make you active, it's going to be beneficial for you psychologically and physically.
I love this program. So much good information. Thank you for researching and taking care of women the way you do. Appreciate you all being here with us. And thanks to all of our viewers for being with us. We'll see you back here tomorrow. Coming up tomorrow on the Morning Medical Update.
And I would constantly think, this could be it for her.
Stacy Lubrick watched her daughter struggle just to stay awake. A surprise infection put 3-year-old Addie into kidney failure. I'm Jessica Lovell on the next Morning Medical Update. Stacy's sacrifice that saved her daughter, giving her life twice. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.